to another Friday edition of Virtual Morning Report. How is everyone doing today? I hope you are all having a wonderful Friday and excited for the weekend. We do have a case presenter today. Is the gentleman wearing that tightly fitted white coat, Dr. Travis Smith. Travis, you want to say a few words?
Good morning, good afternoon. Glad to be here. Looking forward to a wonderful discussion and glad to see you all. And if anyone wants to know, the best white coats, Metalita, they're awesome. I highly recommend.
Dude, was that a Nike shirt you have on too under there? You look very comfortable.
Oh, of course.
Nice.
Try to be like you, man. You know, take off the jacket, show off the guns.
Rafa, do you want to unmute yourself, and then maybe Kirtan can as well? Just say a few words. You're going to be teaching today, and Kirtan's going to be scribing.
Hi, everyone. My name is Rafaela, and I'm a last year medical student here from Brazil, and I'll be doing teaching point today. Very happy to be with you all.
Hello, myself Kirtan, and I will be doing scribing today. I am from India and looking forward to today's case. Travis always has nice cases, so let's see how it goes.
All right, so Robbie will be joining us. He's just running a little late.
Hello.
Oh, there he is.
Good morning, everyone. It's great to see you
Hey,
all.
Kip, how's it going, Dr. Mahara?
The one and only Dr. Mahara is here. Dr. Mahara, oh, he just left. Dr. Mahara is a legendary attending here at the San Francisco VA.
No, Gabriel, it looks like a plum. That's not an apple, right? Is it a plum?
It's a plum.
My diagnostic scales right off the bat. It's going to be a good day.
Yeah.
All right. Kirtan, why don't you take it over? Travis is going to be presenting. And Robbie, do you mind tackling the first aliquot?
Of course.
Excellent.
All right, you all ready? So I have 4 aliquots for you guys. The first aliquot is going to be the chief complaint. We have a 63-year-old female who presents with persistent abdominal pain, and I will leave it there.
Ay, ay, ay. Persistent implies that somebody has tried really hard to figure it out, or it can mean that, it could mean that the patient has had it long standing. But as I digest this plum, I'm going to tell you the truth. Abdominal pain is all about the tube of truth. The number of causes of abdominal pain that require a CT scan for definitive diagnosis is so large that in real life, the question is to scan or not to scan. That is the question. And you should never scan when you can make a diagnosis before the scan. There are 6 diagnoses that you can make confidently and actually meet the diagnostic standard for before the CT scan. 2 on exam, 2 on labs, and 2 on rapid bedside testing. The 2 on exam are a zoster and an incarcerated hernia. The 2 on labs are pancreatitis and DKA. And the 2 on bedside testing is an EKG to diagnose an inferior myocardial infarction and a bladder ultrasound to look and diagnose acute urinary retention as a cause of abdominal pain. That, my friends, is a rule of 6. The 2 and 2 and 2. 2 plus 2 plus 2 is 6. I say that in reference to now the infamous mathematical error of Reza Manesh on the chest pain episode, or he can tell you about that. So the truth abdominal pain is it's all about the tube of truth, but don't scan somebody when you can get the answer in one of these 6 ways. If you think about abdominal pain from a different perspective, you'll realize that the pathology may lie in the abdomen, may lie in the thorax. We just talked about myocardial infarction, and may lie in the pelvis. And so right now the question is, what can we diagnose on exam, labs, and point of care testing? Or are we going to ask the patient to go through the tube of truth? I'll pass the mic to Rez to see like what thoughts he may be having right now and where you would take it from there.
I love that. I felt like we were listening to some poetry. The tooths of truth. I really have nothing to add. I am the only additional layer I'll add to Robbie's terrific discussion is just like with chest pain, when you think about life-threatening causes, we think of ACS PE dissection, or with jaundice, we think of cholangitis, massive hemolysis, or acute liver failure. You should have a list for abdominal pain as well. In this list, there's no gold standard. It's all based on where you practice. For example, if you're at the VA, it's less likely that you'll have ectopic pregnancy as a cause of abdominal pain. But there are a few diagnoses like obstruction, perforation, and vascular catastrophe that should be considered, meaning you just go through the thought exercise. The longer the duration of symptoms, the less likely it is to be an acutely morbid process. I almost think of the time to diagnosis is equivalent to the time to symptom onset. I'll leave it there. And Anna at Fred said, hey, what other questions would you have? I'd be like, well, first of all, where's the location of the pain?
All right, second aliquot. Just layering on, 63-year-old female. She presents to the ER complaining of persistent epigastric right upper quadrant pain and vomiting. She notes the pains persisted since her cholecystectomy 3 months ago. She notes since her surgery, she's been having intermittent nausea and vomiting without diarrhea. She denies weight loss, fevers, drenching night sweats, or changes in appetite. She's still hungry, but she eats and she throws up. She denies any associated chest pain or shortness of breath. Some more past medical history is the cholecystectomy. She also had a hernia repair during that operation, and she's had a prior colonoscopy. She has dyslipidemia and cervical stenosis. She denies tobacco, drug abuse. She occasionally drinks alcohol, denies marijuana use. She currently takes atorvastatin 20 milligrams, and she has allergies to Augmentin. A little more history. So 3 months ago, she had this outpatient laparoscopic cholecystectomy and hernia repair. The operation was followed by a couple complications, which included a possible bile leak and skin fistulization. She had a negative HIDA scan shortly after the procedure, and they determined that there was not a bile leak, but they still thought there was fistulization there between the right upper quadrant and the overlying skin. And she had seen multiple providers after that and had been put on multiple antibiotics like Keflex, which didn't help, and then followed up with Cipro and Flagyl. So that is the end of the second aliquot.
Thanks so much for that, Travis. Maybe I'll leave the more difficult part to Robbie, which is how he sort of incorporates the procedure and the complications of the procedure and how he would go about addressing that if you were taking care of this patient. And then I'll talk a little bit about the geographic location of the abdominal pain and potential etiologies. You see the duration of 3 months, you said, Travis, is that correct?
Correct.
Okay, that's really helpful because tempo is queen in diagnostic reasoning, and this excludes acute pathologies like a perforation, an obstruction, appendicitis. These things can have a subacute course, but 3 months is awfully too long for them. So when you have epigastric abdominal pain, you can think of the G's, the 4 G's, which include gastroparesis, gastric ulcer, gastritis, and GERD. Other organs in the epigastric region include the pancreas, a portion of the duodenum, the aorta, and there are a few causes of abdominal pain that can be diffuse, including in the epigastric region, including constipation, which this would unlikely be the case here, or inflammation of the colon. The itis can occur anywhere within the abdomen. The issue with just taking a geographic approach is that Charmaine will tell you the organs are so crowded that it's so easy to have referred pain. For example, like kidney pain causing left upper quadrant pain. It can happen. But if we now shift our focus to the right upper quadrant, there you have the hepatobiliary system. So anything that can affect the liver or the biliary tract, from inflammation of the liver, congestion of the liver, infiltration of the liver, to something happening within the biliary system, whether it's some form of stones or those stones then being complicated by an infection. And I'll leave the rest to Robbie, but I'll just make one more point. When someone has right upper quadrant pain, they get a cholecystectomy, and that pain persists. The question becomes, was it the wrong diagnosis? Was there something else going on? Was it the right diagnosis and now we're seeing manifestation of another disease, or is it a complication of the procedure?
I love that. I love that framework. I also love the 4Gs. I don't think I've heard that before. That was awesome. I think I don't. It's funny how we upload knowledge from areas that we don't see quite frequently. Like I've seen complications of cholecystectomy, but I don't have a good handle on what the relative frequency of them are. I think that that of course the simple stuff like bleeding, infection, etc., are probably the most common. One of the most morbid ones is bile duct injury. You can imagine that especially in an acutely inflamed gallbladder, it's hard to delineate clearly bile duct versus vessels. And so ischemic biliary injury is, I think, a feared complication that typically happens in a manner delayed. So you can get a biliary stricture. You can also get stones that occur at the stump or at the edge of the margin of the cystic duct resection. You can also get retained common bile duct stones that either formed de novo or were not removed in the first place. As they saw in this case, you can get spillage of bile causing biliary peritonitis. And another morbid dimension is fistulization all over the place. We have a couple of patients here who come in who have ongoing gallbladder. There's a fancy word for it, something cutaneous fistula. The other place that you can fistulize not infrequently is actually the stomach and the duodenum. In fact, there's a really fancy syndrome called Bouveret syndrome, where the gallbladder is fistulized to the stomach, and what leaks out is a stone. And that stone can block the stomach, causing gastric outlet obstruction. So here, I love Rez's approach. Was the diagnosis incorrect, and we're dealing with right upper quadrant pain of another etiology complicated by an unnecessary cholecystectomy? Are we dealing with right upper quadrant pain as a result of cholecystectomy, which might take us back to the original problem, stone disease either in the stump or in the common bile duct, or a complication of cholecystectomy such as fistulization to the skin, which we know, but also to the stomach, which we may not appreciate right now? Or are we dealing with a condition unrelated to this disease process whatsoever? And that's where, again, that now the odds of finding a hernia, zoster, pancreatitis, which is possible. I suppose that might be somehow related to the surgery. You can imagine how you're not supposed to blank with the pancreas, but you accidentally blank with the pancreas. Yeah, I think now the chances that you need imaging are through the roof because the odds of you finding one of these 6 diagnoses is fairly low. So I've had a plum, I've had a banana, and I imagine it's a donut of truth is coming our way in the near future. All right, Travis, back to you.
You got it. Good discussion. And my son would say, next, you need a papaya. My 2-year-old loves saying papaya. For some reason, that's his favorite word. So on the fruit theme. So aliquot 3, I'm going to give you a physical exam. So we have a temperature 36.8, heart rate 72, respiration 16, BP normal at 132/69, ER normal. SpO2 was 97% on room air. In general, she was alert, no acute distress. Her skin was warm and dry. I'll get to the skin exam on the abdomen in a second. Her HENT was normal. Her mucous membranes were moist. Her lungs were clear. Cardiovascular exam was normal. No murmurs, rubs, or gallops. There was no peripheral edema. Abdominal exam, she had mild tenderness in the right upper quadrant. There was a fistula draining purulent fluid from the laparoscopic cholecystectomy site, one of the ports. The skin surrounding one of the incisions was slightly erythematous. There was no guarding, no rebound. Bowel sounds were normal. There was no organomegaly. Neurologically, she was alert and oriented ×3. That's a physical exam. I'm going to give you some labs. So her white count was 6,000. The differential was otherwise unremarkable. Hemoglobin was 12.2. Platelets were 320. Chemistry panel, sodium was 137, potassium 4.1, chloride 108, bicarb 24, BUN 18, and creatinine was 0.9. AST was 24, ALT was 28, both normal. Alk Phos was 76, normal. Total bili was normal at 0.6, and her total protein was 7, and an albumin was 4.1. SED rate was 16, and CRP was 3.2. And I now have I'll stop there unless you want me to give you the CT scan results.
I can briefly reflect on the exam and have Reza see what the labs do for him. And I'll tell you, it's not surprising that the exam is completely normal. I think if you ask yourself where you think the pathology is, when the pathology is deep within and visceral to the abdomen, often the exam, all that it can really tell you is, oh, it hurts in this general area. So most people with non-life-threatening causes of abdominal pain at most have a little bit of discomfort in the area they report. Again, this is why in the modern era, it's all about imaging. It really is all about imaging. And the role of the exam is to help you make sure you're not missing an extra abdominal cause of abdominal pain with seeing crackles in the lobes or detecting pelvic discomfort on gynecological exam. But the abdominal exam, unless there's something popping out of the abdomen, in which case it's an emergent cause, this is not too surprising. And I'll pass the mic to Reza to talk about any labs that stood out to him.
Yeah, that I totally agree with Robbie. And the truth is, in clinical reasoning and when you're taking care of patients, one of the most important branch points is whether the patient is inflamed or not. And that is true of any complaint. Are they inflamed or not? And I bet you, had this patient been inflamed, she probably would have had a more thorough workup building up to this moment in time. But when we look at her, vitals and her labs, there's really no marker of inflammation. And then you look and say, hey, is this patient immunocompetent? There's no reason for us to not think that she's immunocompetent. She's young, 63. Past medical history is quite benign. And looking at the labs, from the white count, the platelet, to the albumin, to even the ESR and CRP, if you correct for the age, I bet you they're within normal limits. So right now, the common causes are not on the table, and it'll be very interesting to see what the CT scan shows. And I'm already priming my mind. What happens if the CT scan is negative? Like, how much further do we need to work this up? Of course, we're in an artificial setting here where Travis has a final diagnosis, but I'm trying to be as authentic as possible, looking for a red flag with the abdominal pain. And Robbie, before we move on to the imaging, what are your thoughts in that domain? Anything jumping out at you that, wow, we really need a diagnosis? Like if the CT ends up being negative, what would your thoughts be?
Yeah, I love that. I love that you're thinking ahead. And for me, I asked myself, there's a long differential diagnosis of which you have a marvelous schema on the website of CT negative abdominal pain. But if you apply the filter of what's emergent, What's emergent, really, that may not show up on CT is mesenteric ischemia, which the timing of the contrast is key, and cholecystitis, which sometimes doesn't show up on CT scan, and sometimes you need an ultrasound. The other thing is intermittent disease pathology like intussusception cannot show up on the CT scan. So there's those three things: mesenteric ischemia, cholecystitis, intussusception, and lastly, not also pertinent to this patient is pelvic disease, like ovarian torsion or things of that nature. So there's those four, and then there's the other 4 A's, and that's adrenal insufficiency, acute intermittent porphyria, and I don't remember the other 2, but I promise you there are 2 other A's. I was trying to save myself by trying to remember the 2 A's, and I was, nah, it's Friday, I'm too tired. Can you remember anything else that's emergent and CT negative? That's all I got for now.
And that starts with an A.
I think it starts with an A. I'm not sure. Here, I can pull it up.
Yeah, pull it up. That's
I'll
great.
pull it up. But yeah, I think none of those, except being like, except saying, hey, you know what, the CT may not show gallbladder pathology or whatever's left of the gallbladder,
Yes.
So should we, if the CT is negative, do we get a follow-up ultrasound? I have the other A's too, by the way. It's anaphylaxis and angioedema. There we go. We did it eventually.
We're giving you G's and A's, folks. Everything in 4s.
All right, Travis, back to you.
All righty. So abdominal CT scan was otherwise normal. Pancreas, kidneys, small bowel, everything was normal, except the stomach. There was a soft tissue mass measuring about 2.8 centimeters within the posterior wall, and there was some thickening of the distal antrum and pylorus of the stomach. And the next bit of information, I'll let you reflect on this, and then the next bit I think will kind of be the diagnosis.
This is extremely helpful. And by the way, it's important to note that, like, when does contrast actually impair findings in certain conditions like nephrolithiasis, when you should do the CT scan without contrast? So those are stuff that's important to understand as you're going in to getting this imaging. So now it's almost like approaching a fever, right? When we have a fever, we're looking for a site of inflammation. Here we have pain, and we're looking for a culprit of the pain. So we have to go where the money is. Where is the money? It's not in the pancreas, it's not in the spleen, it's not in the liver, it's not in the GU system. It's in the CT scan in the stomach. So when you have no other finding, then the likelihood that this mass that Travis revealed is causing this patient's symptoms skyrockets. And just to reframe that, sometimes you'll find findings on imaging that do not correlate with the patient's clinical syndrome. But here we have every reason to believe that this posterior mass, in fact, is what's caused the persistent pain in this patient. So how do you approach a mass? Well, right off the bat, you ask the question, can this be a tumor, whether it's benign or malignant? And that's very important to consider. Think about all those patients who don't get treated with H. pylori and then develop a mucose-associated lymphoid tumor, MALT. But there's gastric adenocarcinoma, there's various cancers. So right away, cancer is a possibility. Infection, unlikely to have this type of presentation because there's no findings to suggest inflammation. So I'm not worried about it. And it would be such an odd place for an abscess. Remember, there's so much acid in the stomach that whatever bacteria exists there is minimal. So that's why you don't really get those types of infection unless it's a unique bacteria like H. pylori. Then we go back to something that Robbie mentioned initially. Could the gallbladder stone have traversed from the gallbladder into the stomach, and it's just too large, or it's positioned in a place where it just hasn't emptied into the duodenum? Because it seems like whatever that mass is, it's causing inflammation in the area adjacent to it in the antrum of the stomach. So it's causing damage by being present. So what do we do next? So we think about the two most likely possibilities, one of it being a stone just hanging out in the stomach, and the other being tumor. The next step is an upper endoscopy to look at what we're dealing with here. But before we do that, let me pass the mic to Robbie to see what other reflections he has or other diagnosis.
Zero.
All right, I have some images I'll share. I think you make me a host and then I can do it. And then after I share the images, if you don't mind, I can just go into some teaching points that we have prepared. Does that work? Okay. All right, are you able to see the, oops. Uh-oh, I froze. That's no good. I'm back. Are you able to see? I froze for a second. Can you see the images? Yeah, okay. So this was what we found on endoscopy. You can see the stone there. And then also there was a little fistula that you can see here in the stomach, and that was the stone after it was removed. So I will stop share and then I'll go through the points. So Robbie got it 100% correct. So this was a case of Biliary syndrome from a gallstone ileus. So the endoscopy confirmed the presence of a large retained gallstone in the gastric body, as well as the a gastric fistula. There was one hemostatic clip was successfully placed to close the fistula. There was no bleeding at the end of the procedure. The gallstone was unable to be removed via EGD, and the patient was referred to surgery where it was removed laparoscopically, and the patient had notable symptom improvement. So the patient was deemed to have Biliary syndrome, which is defined as a mechanical gastric outlet obstruction secondary to a gallstone ileus. Given her history of recurrent abdominal pain and vomiting, it was presumed that her episodes of pain and vomiting were due to episodes where the gallstone was intermittently obstructing the pylorus. So Biliary syndrome is defined as a mechanical gastric outlet obstruction secondary to gallstone ileus in either the duodenum or the pylorus. This syndrome can also occur due to the adherence of the gallbladder to the small intestines, forming a biliary enteric fistula for the gallstone to pass through, causing an obstruction. Gallstone illnesses cause about 1 to 5% of SBOs, the most common site being the terminal ileum. I think that's where we all kind of see it or read about it. The population most commonly affected are elderly female patients. Of 315 cases, Biliary syndrome specifically has been reported from 1967 to 2016, making this a complication of cholelithiasis very rare. Usually they present with epigastric pain, nausea, vomiting. Other symptoms that can be seen include abdominal pain, distension, GI bleeding, weight loss, and fever. Diagnosis is usually either on X-ray, CT scan. Sometimes the stones are missed because some gallstones are radiolucent, and so you can't see them. So sometimes it takes an endoscopy to see it. Other times MRCP will be able to find this. And talking about imaging, someone who has abdominal pain, if you were to do an right upper quadrant ultrasound, you would miss this because this isn't going to show up because it's in the stomach. So sometimes the imaging can be a little tricky to kind of navigate. Treatment is endoscopic extraction or lithotripsy of the gallstone. If these methodologies fail, surgery is needed to relieve the obstruction. And due to the scarcity of cases, a clear consensus on surgical management hasn't been reached. And one last clinical pearl specific to the Biliary syndrome is the radiological triad of Wriggler, which includes small bowel obstruction, pneumobilia, and an ectopic gallstone.
Travis, what a phenomenal case, striking image and terrific teaching points. And I think the group says it all in the chat on how awesome of a case it was. And I think this highlights the power of a schema. I'm going to give the mic to Rafa soon, but think about it. Someone comes in post-cholecystectomy with pain, and as you're creating that schema, whether it was the wrong diagnosis, a complication of the procedure, or an unrelated diagnosis, but once you get to the complication of cholecystitis, and if you create a schema, this will be in that schema. And so schemas are such a powerful way to have a diagnostic checklist. So for myself or for others, if you don't have an approach to complications of cholecystitis, maybe this case serves as an impetus for you to spend an hour creating an algorithm. So when the patient comes with cholecystitis, you're locked and loaded and ready to go. So let me give the mic to Rafa. Thank you, Travis. Terrific case, my friend.
Yeah, just echoing what I just said. Thank you, Travis. It was really, really interesting. So we had a 63-year-old female with persistent abdominal pain. And the first question is actually to scan or not to scan. And we have to remember that our 6 diagnoses that we don't need the CT to reach the final diagnosis. And those can be based on the physical exam, for example, zoster, if you see a rash or hernia, labs like, for example, pancreatitis to increase lipase or GKA with cetonuria, for example, but also EKG that could lead to inferior MI, or a bladder ultrasound that could point to acute urinary retention. And then Reza taught us that we have to rely on emergencies first, for example, in the setting of obstruction, perforation, ischemic, hemorrhage, inflammation. He gave us many examples, including cholangitis, massive hemorrhage, for example, due to ruptured AAA. And then we have to rule out extra abdominal causes like MI, pulmonary embolism, and pneumonia. And then we have to remember that CT doesn't give us the answers always. So we have to remember the CT negative causes of abdominal pain like mesenteric ischemia, cholecystitis, ovarian torsion, adrenal insufficiency, AIP, anaphylaxis, and angioedema. And then when it comes to epigastric pain, which was the cause, we have to remember the 4Gs, for example, gastroparesis, gastric ulcer, gastritis, GERD, but also constipation and colitis, because both can lead to abdominal pain everywhere. And then we have to remember that the pain can also be referred. So Reza gave us this example that upper quadrant abdominal pain due to nephrolithiasis. And then we have to remember that this patient had cholecystitis in the past, and we have to keep in mind the cholecystitis complications. And the rabbi reminded us to think about bile duct injury, biliary peritonitis, blistulization, which was the cause, including stomach and duodenum. And then there is this rule that I learned from church step 2 that is this entity called post-cholecystectomy syndrome, persistent abdominal pain or dyspepsia that occurs either post-operatively or months to years late to the procedure. And this could be due to biliary or even extrabiliary causes. And then finally, you saw that this patient had a soft tissue mass in the gastric posterior wall on the CT. And Reza reminds us that the first question that we have to ask ourselves is, does it correlate to the patient's clinical syndrome? And we have to consider neoplasias, stones, infections, and endoscopy is warranted. And then we saw that this patient actually had Biliary syndrome, and this is a gastric outlet obstruction due to gallstones. So thank you, everyone. Very, very interesting case, and I hope to see everyone tomorrow on VMR.
Thank you so much, Rafa. That was phenomenal.